Uh, Good afternoon, everyone.
Good
I am
afternoon.
Lakshmi from Sneha Society for Counseling. Uh, I would like to extend a very warm welcome to each one of you to this webinar on this afternoon of on a Sunday. Before we delve into the topic for this webinar, I'd just like to give a brief introduction to Sneha. Sneha Society for Counseling is a voluntary organization, and we are basically about 25 individuals, and we help people share feelings of emotional distress without fear of being judged. As counselors, we are aware that with the limited numbers of mental health professionals, lay counseling comes as a very soothing first line of support to address emotional distress faced by people. With this prime objective in mind, way back in 2004, a group of like minded people with experience in the field of lay counseling started a center, especially to cater to the needs of people with severe emotional distress in a safe and non threatening atmosphere. And most importantly, made access to mental health support to all sections of society. Sneha Society for Counseling was formed under the Karnataka Registration Societies Act. We work out of Himamshu Jyotikala Pita School, which is located in Malleshwaram, Bangalore, a very old residential area in Bangalore. Our vision is to have a society where people have opportunity to be listened to when in distress. Our mission to make mental and emotional health a priority. And we follow Carl Rogers' philosophy that everyone has the strength and to address the challenges that they face in life. So, as mental health support people, we try and empower them to make use of their strengths and try to cope with the situation. Clients come to us with issues of relationship between couples, parents, children, anxiety, abuse, depression, grief, anger, low confidence, and suicidal thoughts. We offer both in-person counseling and telecounseling services. Our services are totally free. Besides counseling, we also do awareness programs on mental health and at the schools, at colleges, and various other forums. In our 21 years of experience, we feel proud to say that we have definitely made at least a small contribution to reduce the stigma around mental health. And we have made a positive difference in many people's lives. For more details, you can reach out to on our helplines, which is there at the footer of each of this presentation. Coming to today's topic, why did we choose this topic? Mental health and substance abuse in adults. Of late, we have all been witness to various facts that that there's a very steep increase in mental health issues across age groups, especially post-pandemic. A recent newspaper article shared that the number of youngsters getting stroke has seen an increase of 1 to 2% year on year. That too in patients less than 30 years of age. And this was attributed to factors like sedentary lifestyle, stress, poor sleep hygiene, substance abuse, and so on. We all know that physical and mental health are very, very strongly intertwined. One can impact the other. Another survey, which was done by the Department of Social Justice and Empowerment of India, has reported that 17% of adults in India in the age group of 18 to 75 years, they abuse alcohol. That amounts to, considering our population, it amounts to almost 15 crores of people. Apart from this, there are people who abuse various types of substances, drugs, and the count ranges from 3 crores to a few lakhs. And this study was done in 2018, and I'm very sure if it was done In the recent times, it would be much, much higher. We all know there is a strong correlation between mental health and substance abuse. They have a bidirectional influence on each other. One exacerbates the other. As per a UN report, most of the substance abusers falling in the productive age group of 18 to 35, the loss due to drug addiction in terms of human value is incalculable. With growing urbanization and migration of youth from rural areas to cities, the youth use substance to cope with the challenges of everyday life. Now we have another monster, that is technology abuse. Addiction to social media to cope with loneliness, stress, anxiety seems to be on the rise and a very steep rise. As lay counselors, how can we support people who have mental health issues along with some form of abuse, be it substance or technology abuse? Is there any difference in how we approach and help this person? Will counseling be effective? Are there any limitations to this, to counseling, or is there something more that is needed? Are there any signs which we need to be careful about, especially those who are addicted to alcohol and drugs and who could pose a risk to people who are trying to help them? Having said this, let's get some perspectives about adult mental health and substance abuse in adults from our guest speaker of the day, Dr. Aniruddha, a psychiatrist practicing in Australia. Dr. Aniruddha, welcome to a very wholehearted welcome from all of us at Sneha and all the participants. We are really, really grateful that you're making time to address us at this late hour on a Sunday. And I would now like to request our volunteer Rupa to introduce Dr. Aniruddha to us. But just before that, a few points to be noted for all participants. Kindly mute yourself through the presentation till the Q&A session. And also please post any questions that you may have for Dr. Aniruddha in the chat box, and we will try and address this at the end of the session. Once again, a very warm welcome to Dr. Aniruddha and all the participants.
Yeah,
Over to Rupa.
Thank you, Lakshmi. Again, I would like to wish very good evening as usual. And it's my pleasure to introduce today's speaker, Dr. Aniruddha. Dr. Aniruddha works as a consultant psychiatrist in the public health system in Australia. He leads a team of clinicians across various disciplines: psychology, social work, occupational therapy, and psychiatric nurses to provide care for individuals suffering from severe mental illness in the community. He also provides consultation, advice to teams within the hospital setting for patients who are admitted for various physical health difficulties and have a comorbid substance use disorder. He subscribes to the person-centered approach in the provision of clinical care. During his training in NIMHANS, Bangalore, he had the privilege of working with some of the leading researchers in mental health and gained experience in brain image analysis. Outside of work, he enjoys spending time with his family, walking his dogs late, playing some tunes on the piano and flute, and binge watching the latest series. Once again, a warm welcome to you, Aniruddha, Dr. Aniruddha. Thank you.
Thank you so much for that kind introduction, Rupa, and thank you so much again for that fabulous work that Sneha Counseling has done over the last 21 years. I must really sort of take my hat off to you in terms of everyone who's volunteering and doing this work on a day-to-day basis, because it is not easy, and that you are devoting a fair amount of your time as well as your emotional space in terms of helping people. Now, I know the introduction and the invitation did say mental health and addiction, or rather substance use disorders. And I think as I was making the presentation, I just realized it was just becoming this this unwieldy beast in terms of how much there is to cover. So I apologize in advance that I've sort of I took the liberty of taking out the large mental health aspect of it, but decided to focus on addictive disorders. So if any of you came in with some expectations, I'd be more than happy to take questions after this as well about any other concerns. But hopefully this will address uh, some of the things that you deal with on a day-to-day basis. And again, thank you all for making it on a Sunday afternoon. I might start off by saying the thing with Zoom is I can't really see everyone, so I don't really know who I'm talking to. But I'm hoping that everyone's had their afternoon coffee or is getting their afternoon coffee. Talking about substances of addiction. So just an outline of the presentation today. I thought I'd just take you through the history of substance use, how we classify it in common mental health parlance, and look at addictive disorders specifically, especially looking at what is addiction, who's using substances, particularly in India, what leads to addiction, what do we do to treat it, how do we support families, and preventive care. Now, I guess I'd like to open up by just sort of saying, what are the substances of abuse? What do people think are substances of abuse? Because there's a wide variety that people sort of are aware of. And if you don't mind, pop your answers in the chat box. I'll try and see if I can actually access it, but it doesn't look like I can at the moment. But in any case, I'll probably move forward because I'm fairly certain that a lot of you are aware. The most commonly used substance in the world is caffeine, which is sort of why I opened with, if you all had your afternoon coffee, which is a common thing if you're all sitting and look, it is classified as a stimulant, and a large proportion of people actually use it. So if you look at this is sort of a drug wheel, and it's an interesting sort of slide because it sort of gives you an overview of all of the variety of substances. It doesn't cover everything, of course. There's the new and wonderful drugs that come up every other day, but it sort of divides drugs in certain categories. So there are stimulants, which includes caffeine, methamphetamines, cocaine, nicotine, which is sort of the active ingredient in cigarettes. Then you have cannabinoids, which are cannabis. Then you've got the opioids, which is essentially heroin. You don't see a lot of heroin use in India, but you see a lot of other prescription pain medication in India, something like tramadol, if you may have heard of it. Then you've got the depressants. You've got alcohol there, which is a major depressant. People aren't aware of it, but it is actually a central nervous system depressant. So you've got a whole variety of other medications. There are some anesthetic agents, ketamine, and there are obviously psychedelic agents. So you're probably familiar with LSD, and which has been sort of featured in a lot of films. And you've also got empathogens, which again, these are substances that make you feel quite differently, feel like you're one, give you a lot more energy. So there's MDMA, that's sort of what it's classified. So I guess this gives you a larger perspective of what people can be using. And I think it's helpful to sort of go back to as a reference guide as well. So say someone comes and says, hey, you know what, I've been using this, you know what they're talking about. Now, I think it's really important to sort of look at the history of substance use, right? So it's not something that's new. And hominids essentially are so essentially beings that were prior to humans as well, so apes, and the theories are that psychoactive substances sort of evolved alongside hominids. So essentially it's interesting because our brains have receptors that are particular for substances, and what people have sort of theorized is that along the years humans sort of use substances to enhance their physical ability. Before it was used to be from a plant, so it wasn't as psychoactive. It took some time for the body to metabolize it and for it to actually start working. So people used it in small amounts and it was all right. So if you look back at history, so nicotine's been used for about 40,000 years ago. That's a long time. And we're still talking about it today. Here we are. We have the most number of deaths across the globe are because of cigarette smoking, right? So you think about it, we haven't really, we've come so far, but we're still using the same substance. And I think that's got to do with how we've managed to purify the chemical, how we've been able to get more potent sort of drugs. And I think our brains haven't evolved well enough, right? So if you look at cocaine, cocaine's been used about 5,000, 7,000 years ago. So these are from coca leaves. Nowadays, you get industrial grade cocaine, which is so potent. So our brains have not evolved to the point where they're able to differentiate that, and that sort of takes a hold. So I think it's really important to contextualize where that is. And look, another commonly used substance, commonly used, which is, and I think India sort of historically, India sometimes is associated when you talk about drug use, cannabis, because I guess there's the cannabis indica species, and it's been mentioned in some of the historical texts and has been used in both a cultural, religious experience, has been used in pain. So cannabis has also been used quite frequently. And I think when we look at alcohol, which is again one of the legal substances most parts of the world, except I'd say a few countries where where alcohol isn't used, and I think those are probably for religious reasons or maybe stronger laws. Alcohol also has sort of been used for many thousands of years. So I guess this is sort of to contextualize that this is not a new problem, but the problem has become larger due to multiple reasons, as I'd sort of spoken about in terms of purity of substances, the availability. There's a whole host of things. Now, talking to this, so I guess working as a psychiatrist and a mental health professional, and the reason I bring this up is if I were to get, again, I really can't see a show, oh, there's a chat box there, great. So I guess if I were to ask someone a question, what is addiction? As in, so if someone uses alcohol once a week, do they have a problem? If someone uses alcohol 3 times a week, do they have a problem? What if they're using it once a month? Is that a problem? Right? So I think, I guess in terms of people wanting to raise their hands in terms of what they understand about it, happy for you to put it down in the chat box. But I guess what psychiatric manuals as such have put forth is they've given us a sort of guide, and these are sort of consensus-based guidelines in terms of what we would define as problematic substance use. Now, the reason this is the case is psychiatric illness and substance use are unlike physical illnesses. There are no clear parameters or blood tests that we can do. So, for instance, if I've got diabetes, I can check my sugars. I know I've got elevated sugars, I've got diabetes. But with substance use disorder, there are no parameters. Like yes, there are brain changes, but it's not that if there's one particular change that I can say for certain this person has an illness or not. So I hope that makes sense. So I guess these are the 2 classificatory systems that we use to diagnose someone with a substance use disorder. So one is the Diagnostic and Statistical Manual, which is primarily an American-based one, and the other is the International Classification of Diseases, which we use in India. This is a bit information heavy, this slide, and the reason is so these are the 11 criterion that the DSM-5, the Diagnostic Statistical Manual, uses to make a diagnosis of substance use disorder. So just so you're aware, you don't have to go through it all, but if someone has 2 to 3 of these criterion that are met in the last 12 months, they have a mild substance use disorder. 4 to 6, they have a moderate substance use disorder. Anything beyond that, they have a severe substance use disorder, right? Now, so I think it's important to look at each of these criterion because they satisfy a certain sort of parameter that we're looking for when someone is using substances. So if I was drinking alcohol once a week and I had 1 drink and I was perfectly all right, I may not qualify for a substance use disorder. But if I was having alcohol every Saturday, I went out at 8 o'clock, I was drinking, say, 5 drinks. I said, you know what, I'm going to stop at 5. But by the time it reaches 12 o'clock, I've already had about 10, right? I get back home later that night. I probably get in my car, which I'm not supposed to. I drive back home, so I'm putting myself and others at risk. Then I get back home to my wife, and she's like, oh, you're back home drunk again, are you? I end up waking up late. I don't do my chores on Sunday. I don't take the dog for a walk. I don't feed the dog. This again sort of boils down onto Sunday afternoon where I'm feeling a little sick. I'm like, oh, shucks, I don't feel good. I'm feeling anxious. So what do? I reach out for another glass of whiskey. So what happens then? It sort of boils over to Monday where I'm hungover. I don't feel I'm ready to go to work. So I call in sick. I don't go into work. And uh, this sort of becomes a constant area of friction. Now, this is 1 week. The next week, instead of 8, it becomes 10. So I guess the picture I'm trying to paint here is that it's not something that happens overnight. It's something that happens over a period of time. And also to look at the various domains it sort of affects. So it's impacted my personal life. I go in saying I don't want to drink more, but I'm drinking more. And it's impacting my work. And it's also causing a fair bit of risk because I'm driving when I'm intoxicated, which obviously is not great. So I'm doing it in risky settings as well. So that's just to give you a brief overview of what a substance use disorder diagnosis might look like. Now, ICD-11, again, these are the criterion for diagnosis. So basically, this is a little more simpler, right? So if you were to look at it, how would you say someone has an issue? They have impaired control over the substance use. So essentially, a loss of control is very important. So what that means is, if I say, today I'm going to have 2 drinks and I'm able to put the brake on it, great. But if I go on and have 5 drinks, maybe there's a problem that I need to think about. Then if there is no alcohol, say for instance, Saturday night, I'm going out with friends, and if there's no alcohol, I just don't feel like I'm enjoying it. I'm not having a good time. So, what happens then is alcohol needs to be present in everything that I'm doing. So, what that means is taking precedence. So, that's something that we call salient. So, what happens over time is interest in other aspects of life becomes really low. So, if I enjoy binge watching television, I probably lose interest in it. I'm just drinking all day. If I enjoy walking my dog, I don't. I'm just drinking all day. And then the last feature is if I'm not drinking, I end up with withdrawal symptoms. I get tremulous, I get anxious, I start hearing voices, I get very edgy. And over time, if I was drinking 8, I'm now drinking 20. So that's increased. So that's something that we call tolerance. And then I end up in hospital, I have jaundice. Despite me having jaundice, I will still reach out for that bottle of whiskey. So I'm using it despite harm. Now, I know this is a fair bit to sort of take in, but just to give you an overview of how we make that diagnosis. Any questions so far? Please sort of pop that in the chat box. I think I do have access to it, so I'm going to try and see if there's any questions up there. No. Any amount of alcohol has adverse effects, no safe amount. That is a very good point. Yes. So I think, look, various sort of various countries have sort of limits in terms of what they consider, but I'd probably agree with this. Any amount of alcohol there's no clear safe amount. People say have a glass of red wine. There's really no truth to that in terms of it having a good amount. In Australia, they sort of say have about 10. The permissible limit is about 10 standard drinks in a week. So again, that's something to contextualize. That's a fair amount. Now, show of hands, if anyone can unmute themselves and just say, what do you think is addiction? What is addiction? And no stress if no one's sort of up to sort of talking as well. But
when we crave for something, and we'll do anything to get it, we don't do our work, we would, focus on that. It's, the substance per se.
Yes. Yeah. So I think you've really highlighted some points there in terms of craving. You've highlighted points in terms of the salience, like we spoke about as well. I guess it's the reason I bring this up is there's also a moral view towards substance use, right? And this is prevalent in a lot of societies. And I can see obviously a lot of things coming in the chat box. Yes, inability to control, addiction means in layman, inability to live without. Yes, yeah. I guess the reason I bring this up is the model that I'm presenting today is that of a biomedical model. So it's a medical model, a brain disorder model. There's also the moralistic model where we talk about, oh, this person's making bad choices, they're a bad person, they should stop. Why are they continuing to drink? They have every control over it. Right? Now, and look, that is sort of the prevalent view across and I'll be honest, it's across health professionals, people who've trained in this field, people who provide help for other people. Again, I think it's largely to do with awareness. So I think what I have found helpful in the work that we do, again, is to sort of, because at the end of the day, we hold the space for hope. We give people the space that they need, right? This is a very difficult condition to be living with. So what I found helpful is to sort of conceptualize this as essentially a treatable. So this is the WHO definition, and I mean, sorry, the ASAM definition. Again, the WHO also subscribes to this. It's a treatable chronic medical disease, which involves complex interactions among brain circuits, genetics, environment, and individuals' life experiences. So people with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. So I think it touched on a few points that were shared in the chat, touched on a few things that were already mentioned in terms of craving, being unable to live without. So I hope this puts things into context. Any questions so far? All right, so I'll move on to the next. So who is using substances? And I think, as was alluded to in the introduction, I think there was multiple surveys that were done, the latest, probably 2018. I have sort of taken an excerpt from an article. So this is from Understanding the Epidemiology of Substance Use in India. This sort of summarizes a whole bunch of surveys. Look, the thing is, to be able to accurately say how many people are using or how many people suffer from an illness is a mammoth task. It is quite challenging, particularly when it comes to substance use as well. So what we tend to resort to is looking at surveys. So there are household surveys that are sent out. There might be, so it's sampling. So you send out surveys to a few people, you draw statistical averages from that, and then you extrapolate that data. So just for context, so these are all numbers that are sort of brought from there. This is just to give you an overview. So largely across the globe, what they've noticed is, and this is specific to India, but I'm also saying that largely across the globe, men use substances more than women. Interestingly, in India, they've noticed that tobacco use has been reducing across the population, which is good. Now, I know I'd received a few questions beforehand. There was also a question around vaping. So look, I'm going to try and address some of those questions through the presentation. And if I haven't, please, I just want to reiterate that it's not that I haven't looked at it. Please feel free to ask me those questions again if there's something that I haven't touched on. I've tried to incorporate that. So I know there was questions on vaping. So again, vaping, I don't know if it was actually captured in the surveys as such. And again, looking at alcohol, this sort of put it at about 14.6% of the population using alcohol. A smaller proportion, maybe about 4 to 5%, are actually dependent. So that means they satisfy all the criteria for use disorder or dependence, as I put out earlier. And I think a concerning phenomenon that has been there even while I was practicing back in NIMHANS as a trainee, there was inhalant abuse in the adolescent age group as compared to adults. This is a common feature, and I think that's also sort of growing across. And inhalants, so essentially these are things like glue sniffing, petrol sniffing, anything that has, so essentially these are things that are easily accessible. People wouldn't necessarily associate it with a substance of abuse, becomes easily sort of accessible to children as well. Now, talking about premature deaths, so like I mentioned, smoking, 7.7 million deaths attributed to smoking, right? And due to alcohol, about 2.4 million deaths. So I think putting this into context, drugs, substances really have an impact on people's lives, irrespective, either mental. So we talk about morbidity and mortality. So morbidity is essentially living with illness or afflicted with something. So it has an impact, both physical, mental, as well as contributing to death. Now, does anyone have ideas on what leads to addiction? Why do people get addicted? What do they think is happening? Oh, great. We've got some fabulous responses here. Someone already talked about the hijacking the reward system. Substances destroy natural way of seeking pleasure. Depression, yes. Jennifer says depression, loneliness, peer pressure. I think these are all really, really important. Yeah. Market ads. Oh, that's yes, advertisements. Yes, the surrogate ads in India.
The peer pressure, especially it start in the school and the college time, the gateways time, and then they are unable to control it afterwards.
Yeah, absolutely. So what maladaptive coping, great. I think you've all hit on very interesting topics, right? So I think there are risk factors, and I think it sort of touches on some of the things that you already mentioned. So one I'd like to preface is that a person's genetics can have an influence. So what that means is there's no particular gene. It's not like I have this gene, oh, that's why I'm going to use substances. But it's called a polygenic inheritance. So there are people, families. So there are lots of studies as well. And if you want later, I can sort of share those studies with you. There's a lot of work that's happened in NIMHANS as well in terms of looking at children of people who have a substance use disorder. So their genetics can contribute to their risk of using substances. Age at first use. So I think early age, if someone starts using substances very early on, that is a huge risk factor for long-term substance use. So I think making sure we're able to give children and adolescents a protective sort of period around that time is really, really important. And I think touching on some of the factors that were already mentioned, the psychological factors. So someone's depressed, someone's anxious, presence of other mental disorders, say attention deficit and hyperactivity, post-traumatic stress, loneliness, as someone mentioned, COVID-19. There was a huge, huge issue with loneliness and being disconnected. Now, gender, men, again, there's a lot of theories around why this is, but men are more likely to have problematic substance use. And then talking about environmental influences. So this is also key. So when children are in their formative years, they have influences from peers, someone who's a kid who's smoking outside of school or someone outside of college, this pressure, you want to fit in, you want to belong. This is one easy way in. Oh, why are you standing out? Why aren't you holding the cigarette? So there are small things that sort of add to it. And I think lastly, even the family involvement, right? So I think parents not being involved, parents being disengaged, that can also really contribute to children potentially using substances as well, right? Lack of parental supervision. Now, I think someone's already touched on this, and I think it's important to look at why do we enjoy certain things as people, as humans, and does anyone know what gives us an idea? I think there's already been an answer. So what I might do is I'll trudge along. So I think what I was looking to discuss was the reward circuit, right? We are all human, and most. So I'll probably talk about most mammals that way, but I'll talk specifically about humans. So we all have something called the reward circuit. And this is essentially to do with motivation. And everyone, I mean, I'd probably talk for the majority. I'd hope that most people here enjoy chocolate. So you'd enjoy chocolate, you'd go back and eat it. You think of that first time that you had chocolate, or the first time that you had Dharwad peda, or the first time that you went up and had that Nandini Doodh peda, right? That is an incredible memory, right? So every time you go past that Nandini milk bar, you're either looking at that cold badam milk or that doodh peda, you're triggered. You're like, oh man, that feels good. So why does that happen? So I guess that's sort of what the brain does. And that the brain allows us to do that because we need to enjoy eating food. We need to have sex to procreate. We need to be able to do things to look after the ones that we care about around us as well, right? So there needs to be motivation. So as I think I'm sorry, I'm just going to pull up the chat. I think Vishwanath had pointed out, or I think it was Dr. Vasudevan as well, talking about the dopamine system, and Shweta as well. So Shweta, so the next couple of slides will sort of talk about it. Like I mentioned, it's essential for motivation, learning, habit formation, and the brain has multiple neurotransmitters, dopamine and others. So we don't have to get into the depths of it, but essentially this is something called the ventral tegmental area, which is the VTA and the nucleus accumbens. We don't have to get into the technicalities, but this is the basic reward circuit. Is my mouse visible to you or not? If
it is,
it is
visible.
okay, great.
Yes.
Oh, great. Yeah. So I guess what happens when a substance is sorry, some issue with this. So I guess what happens is when we use a substance, so you can see all of these, they act on these receptors. There's an increased dopaminergic release, and essentially that sort of hijacks the reward pathway, right? Now, over time, what happens is this is sort of the cycle that we look at. So it's called the binge intoxication. So first is the first time I take a hit of nicotine, I'm like, oh wow, it's really good. Like I get a high. All right. Then what happens over a period of time when I don't have it, I start feeling anxious. I start feeling edgy. So that leads to the withdrawal or the negative effect, which is again dealt with another part of the brain. So what do? I go and reach out to it again. And then there's the other part, which is the preoccupation or anticipation, right? So put this down to the Nandini Peda. Say you're walking down walking down your road, you see the Nandini milk booth. The first time you have that, you have this rush, right? You're obviously not going to get withdrawal from eating Nandini Peda, but I'm just giving you context because the preoccupation or anticipation is something that's real, right? So think about Diwali when you make sweets, or think about Janmashtami when you make murkus at home, right? There is an anticipation. Oh, wow, I'm going to eat that. So your brain remembers. So what happens is when substances are in the mix, they hijack this system. So every time there's nothing, you're looking to get some more. So this is just sort of an overview of what that is. Now, you can ask, is it just substances? What else can hijack it? So behaviors that can be addictive. And I think this is something that people also spoke about in the question. So there's gambling, there's sex, there's gaming, and these are all disorders that have been included in the classificatory system. Now, I think more and more, I think India is also moving towards a point where I think there was some legislation around gambling, if I'm not wrong, more recently. Prior to that, it was illegal. Working in Australia, gambling advertisements are rife. So gambling is there everywhere. You have a gambling sort of machine 2 roads from where you live, right? And the organizations don't really pay attention to the impact it actually has. And in all honesty, this behavior is actually ridiculously problematic because of the amount of financial loss that it actually causes. It's a very, very hard addiction to address as well. Very similar with sex and gaming. Sex can be a little more taboo because I think people are a little afraid to talk about it. They don't know when to come forth. They don't know what is compulsive sexual behaviors as well. So I think that's also sort of important to contextualize. More and more we're seeing with youth these days is internet use and gaming, right? I remember training as a resident in NIMHANS. This was in 2013, where the first time I'd seen a young boy, 24 years old, been brought in by his parents. He's like, this guy's not getting out of his room. He's just spending 18 hours there. He's eating, drinking, doing everything there. He's lost weight. His vitamin E levels are low. So I guess to put it into context, there are behaviors that can actually also hijack that system. So I think it's really important to look at how we address that. It's not a simple issue, but we can certainly address it. And I think we'll talk a little more about that. I think other key issues to look for when we're talking to people are risks, right? Which are early life experiences. And I think there was another question around adverse childhood experiences. Adverse childhood experiences are essentially any traumas that children undergo, unstable family environments, a family history of substance use, an early parental loss. There are multiple things that can set children on the path towards starting to use substances. They're about 2 to 4-fold increase in risk of initiating substances. Now, you can sort of talk about this, and I think Sneha is doing a great job in terms of spreading awareness in schools. I think that is wonderful in terms of getting children to be aware, and people might be even open to talking about it. A lot of the times, children don't know what is normal. Don't know it's not okay for your father to come home, be intoxicated, and beat your mother up. That's normal for some, right? So people don't know that. So I think it's really valuable work. Now, I think another risk to look at is when is someone the most vulnerable? And I think adolescence is probably the most vulnerable time. To give you a little bit about history about the brain development, so the brain continues to develop. It's in this continuous flux from the time you are young and fully sort of developed by about the age of 25, right? So it's not even 18, it's about 25. So neurons develop. There's this process called pruning. So what that means is there are excess branches, say for instance, are cut off just to sort of. So what happens when someone uses substances during that time is this entire process is impaired, right? So this is a very, very crucial period for brain development and the risk of substance use. So again, there's multiple factors that can influence someone to go on to use substances during this period. It's also a period where people like to experiment. And while the brain is developing, right? So the brakes aren't fully developed yet. So as an adult, you're able to take measured decisions. What does that mean? Say you want to go out for a trip to Bali, right? You don't have the finances. You will make a plan. You'll think about, okay, I want to go to Bali. I need to work for the next 2 months. I need to save X amount of money. I need to plan all of this around, right? If it was a kid, they'd be like, you know what? Got a credit card. I'll just go ahead. Let's go have a good time. So there is really no thinking about the consequences, right? And so essentially, what I'm trying to suggest is the ability to weigh up the pros and cons and do all of that in a measured manner is also impaired while a brain is developing. There can be other factors that are leading to that as well, which can be a comorbid mental illness, other issues that are happening around that time, but it's important to be aware of that. As I stated earlier, genetic factors. So they make a person more vulnerable. There are some people who can metabolize alcohol much more quicker than someone else. So what happens is if I were to drink 3 drinks and person X was drinking 4 drinks, person X would have finished those 4 drinks and would be happy and there wouldn't be any concerns. He'd be walking straight. But I, on the other hand, with 2 drinks, I'd be like slurring and things like that. But what that means to say is that is again genetically sort of driven. So what that would mean is X might be at a higher risk of drinking a lot more because he's not getting intoxicated. And again, there are certain brains that are a little more susceptible, and a certain brains that don't really necessarily perceive withdrawal as such. Now, psychiatric disorders in themselves can be triggers for using substances. So I'm not sure everyone's familiar with attention deficit and hyperactivity disorder. It's a developmental disorder, usually is seen in children under the age of 8 years old, goes into adulthood, but it's sort of the hyperactivity bit of it sort of peters out. These are children who may not pay attention in class, are really running around a lot. They are hard to manage sometimes. And I think school teachers often will find them hard. They're probably put in the naughty corner, called to the first bench, sent to the principal's office, whatever else, right? So I think it's important to screen for that. What this does is their risk of impulsivity. So what that means is their risk of making decisions on the fly without thinking is much higher. Their risk of seeking novelty, which is I want to get new experiences, is also high. Their risk taking is also very high. So I think they are at a higher risk. Mood disorders. So I think people can sometimes have a disorder like bipolar affective disorder, where you have periods of mania and depression. Mania is where someone's excessively happy or irritable. They don't sleep for days on end. They are really driven. This is not, so you'd be able to identify it. So during these periods, people might actually start using substances. And this can happen even when they're depressed. They might use substances to feel a little better. People with anxiety disorders also tend to have a higher risk of developing alcohol use. So, for instance, if someone wants to engage with their peers, but they're anxious, oh, what will they think of me? I don't know what they're going to say. They might have a drink of alcohol and suddenly that anxiety goes away. They feel confident. So that again leads to them drinking lots more. Psychotic disorders, on the other hand, psychotic disorders are disorders like schizophrenia or schizoaffective disorder. There is a link between cannabis, stimulant use, and psychotic disorders. It's bidirectional, but again, there's a lot of information on this. So people who use cannabis and people who are susceptible, they tend to develop psychosis. There's a small proportion of them who are vulnerable, And cannabis users are at a higher risk of developing a psychotic illness. So what that would mean is they can become delusional. They believe that someone's after them. They start thinking weird things. They start hearing voices. They feel they're being controlled. So that is an effect of cannabis as well. So I think that's something to also bear in mind. How do we treat addiction? Now, I think it's important to remind ourselves that this is a chronic relapsing condition. So I think it's important to be prepared that you're in it for the long haul. That, yes, maybe there are people who might benefit from it. And I think in the setting that everyone at Sneha Counseling and everyone else who's doing other counseling work is involved, you're probably not seeing the pointy end of the stick where people are dysfunctional to the point that they're not able to show up for appointments. You're probably seeing people way ahead, which is really positive, where you can actually effect change. I think here it's important to talk about what does the person want? Because look, the parents can want something, you may want something, the person may not want to change. Do they want to stop? Do they want to reduce? Do they want to continue to use? Say, for instance, they're drinking 3 times a week. Maybe they want to cut down to once. Do they have to stop because of health consequences? So I think it's important to start a conversation about saying, okay, you know what? You're using substances, stop. The conversation should be, what do you want to do about it? Do you want to change anything about it? Is there a reason for you to change? And I cannot emphasize this enough. And I think in the introduction, I think you already led with this. And it's really reassuring and very heartening to see that you lead with person-centered care. There's this Rogerian sort of emphasis in the care that you provide. And I think that is the key, because people who use substances are often stigmatized. They are always called names. Bidapaun, Kudka, on Madala. The impact on that is so many-fold, because we do not stop once to acknowledge what that person might be going through, right? So I think leading with that person-centered care and empathy is really important. Using non-stigmatizing language, I think that's also important, where we don't talk disparagingly about people who use stuff, because they are, after all, people. We don't choose our lives here. We get dealt the hands, whatever we have with our genetics and whatever else, and we make do with what we can based on the environment we grow in. I think the key is providing a safe space which you'd be able to afford in a counseling session, and ensuring confidentiality. I think that is also key, because I think stigma plays a role here. I think unless there are significant risks, so if someone's saying they're going to do something to themselves or hurt someone else, or if you're dealing with a minor, I think those are probably instances where you might have to sort of weigh up the confidentiality aspect of it. And I think the other key is focusing on what the person wants for themselves. And I cannot emphasize enough this therapeutic engagement. You might see a person for 6 months. That in itself is good. The fact that they're coming to you every week or every couple of weeks in itself is very helpful. Talking about treatments, so there's definitely biological treatment. So that's sort of what I offer on a day-to-day basis. So if someone's drinking large amounts of alcohol, withdrawing from alcohol can be life-threatening. So if someone's drinking 3 bottles of whiskey a day, you always tell them, do not suddenly stop drinking. If you want to cut down, maybe cut down by 1 drink a day. Why is that? Because it can be life-threatening. People can have seizures. They can have a condition called delirium. So it's very important that they seek medical attention. So that's why we have medically assisted detox, where we give them medication to help them come off the alcohol safely. Following that, there's medication that we can provide, particularly for alcohol. There's anti-craving medication. It tends to work best when someone's doing therapy. So they're engaged in psychological work. Talking about nicotine, there's nicotine replacement options. This is something that we can offer to people who vape. Again, it's important to look at whether they want to stop vaping or not. On one hand, this is a debate that we can have. Is vaping safer than cigarette smoking? Potentially, because there are lesser chemicals that you're using. Is it safe? Probably not. And I guess talking about opioids, so this is another treatment that is life-changing, where people are using heroin or they're using pharmaceutical medications or pain medications, tramadol, anything that they're taking. We can get them onto safer alternatives and get them to lead functional lives again, where all they're doing is not thinking about where they're getting the next fix from. Psychological treatment. So I think this is in the long haul. There are various types of therapies. Motivation enhancement therapy is essentially a therapy where we look at change, right? Now, this is true for all of us. There are behaviors that each one of us probably have that someone else dislikes or would like us to change, right? It doesn't matter if you tell them 100 times. If they don't want to change, it will not happen, right? So someone needs to make a decision to change. So motivation enhancement therapy is about looking at making and enforcing that change with someone. What that does is you weigh up the pros and cons of your decision. Do you want to continue drinking? What are the pros and cons of that? How can we help you deal with that? And you've got to let that responsibility lay with that individual. I won't go into the depths of it, but happy to take any questions. There's other types of therapy that can help with comorbid disorders. Say there's cognitive behavior therapy for anxiety and depression. There's group therapy as well, which can sometimes be really, really helpful because when people can feel alone, right? Alone in this journey. Oh, I'm giving this up. It's a huge part of their lives. And when they hear this from someone else who's been in a similar situation, it's a lot more reassuring. It's like, okay, you know what? There is someone who can help me with this. There's someone else who's been through this. Then there's family therapy. There's external organizations like Alcoholics Anonymous and Narcotics Anonymous. There's some online resources as well. So this is sort of to look at the stages of change. I know coming to the end of the presentation. So this is the stages of change by Prochaska and DiClemente. This is the fundamental basis of motivational enhancement. So what does pre-contemplation mean? That means someone doesn't really want to do anything about their substance use or any behavior they want to change. So apply this to any behavior you think someone wants to change, right? What is contemplation? I'm thinking about it. Oh, you know what? I think I need to wake up on Sunday and walk my dog on time. I think I should probably cut down how much I drink on Saturday. So I'm contemplating. I have not said I'm going to stop. Then I say, okay, you know what? I need to make a decision. I'm going to try and stop. And then we make an action. So what is that action? I say, you know what? On Saturday, I'm not drinking anymore. And then there's the cycle of relapse again, right? So again, it's important to bear in mind that relapse is continuous. It's this continuous cycle. So I think where counseling will come into play is pre-contemplation. It'll come into play in each of these stages because they all need different approaches, right? You're not going to do the same things with someone who's in pre-contemplation or with contemplation. Now, there was a very interesting questions on relapse prevention. How do we address it? So I think it's important to look at what are the triggers for someone who's drinking, and it's different for everyone. Someone might drink because they're feeling sad. So how do we talk about not going and reaching out for substances? You talk about what can you do when you're sad? Can you talk to someone about it? Can you look at doing art? Can you paint? Can you go for a walk? I don't know. So it's just about working that through with them. So it's about managing cravings. Craving is another major important thing. So there's obviously medications that we can offer, but it's also about psychological means of managing craving. There's dealing with peer influence and social circumstances, because if they're using in a group, it's a loss of friendship. It's a loss of social connection. What do I do? If I stop drinking, I'm not going to be able to meet my friends. How do I manage that? Does it mean I have to cut them off? Will they be understanding enough? Will they say, you know what, it's okay? And I think the last thing is also about addressing any underlying psychiatric condition. So if there's anxiety, if there's a mood disorder, that needs to be addressed, because that again can be a trigger for relapses. So is treatment effective, you may ask? Yes, I think look, relapse rates are pretty high, right? So people relapse, 40 to 60% of them. There's probably one or two studies that say it takes about 25 years for someone who's dependent on substances to actually achieve sobriety. I think the key is just to keep at it, continue to seek support and treatment and the therapeutic engagement. I cannot emphasize that much, because when we sit in the position on the other side of helping someone who's in this position, there's not a lot of people there willing to give them a listening ear. There's not a lot of people who want to hear them. So you can be that person. So I think that's really, really empowering. Another part of this is supporting the family. This is never easy. And I think when you look at the socio-cultural and socio-economic milieu of India, it becomes a lot more complicated because there's gender biases, there's earning members of families, there's family violence, there's domestic family violence there even here. But uh, again, when people don't have the means to seek treatment, they are sort of subject to this on a day-to-day basis. So I think it's about doing what we can with the available resources. I think one is assessing their knowledge, empowering them with information, getting them to do things for themselves, trying to help support them. Say, you know what? If he's getting you to buy his drugs for him or alcohol, maybe say you can't do it anymore. Will that increase their risk? Possibly. So I think it's about weighing that up as you discuss that with them. And then also empowering them with looking at other avenues, getting them to seek treatment, either medical, going the legal route, or even engaging with law enforcement sometimes. And those are rare circumstances. And I think the preventive care is probably the key in a lot of this. There's facets to this. You've got demand reduction, where I think Sneha is doing a lot already in terms of education, increasing health awareness, and managing stress. You talk about supply reduction, where you talk about policy level determination, where government makes laws. You determine how much illicit substance use. A very contentious issue: should you ban a substance? Should you not? Because look, we are, after all, a very creative species. You ban it, we'll find ways of getting it. You ban it, we'll find ways of making it. There are people in prisons who use substances. They have innovative ways of getting substances in there. So again, banning has some effect, but does it really stop it? Unlikely. And I don't know if it's really a solution, but sometimes it might be. And I think another key to take home is harm reduction. So what that means is it's always about looking at reducing harm. So if you're talking to someone and you're able to say, if you're drinking 10 drinks a day, you bring it down to 8, that is a win, right? You're at least reducing the harm. You're injecting heroin 3 times a day. You're at least use clean needles or cut it down to a little bit. You're smoking 10 joints a day, reduce it to 5. Maybe smoke only on the weekends. That in itself is a win, right? And I think the key is about minimizing stigma and not ostracizing individuals and not characterizing them as evil or. Are there individuals who are probably breaking the law? Yes. Are there people who are probably antisocial? Yes. So I think you can call that out when it's there. But if someone is coming to you with a substance use disorder, I think it's really important to look at minimizing stigma. The last couple of slides. So I think this is just an overview of things, and I'm happy to share these slides. You can have a read of them later if you need. I think life skills, I cannot emphasize this on enough, because I think these are really important in the growing years, where children ought to be taught how to actually approach problems. And I think this really allows them to feel empowered, make decisions for themselves, which are positive in that regard. There's a fair few life skills sort of sessions that are run. I know Nimhans runs one. There's quite a few other workshops that do it as well. I know a very close colleague also who's doing it for children who are impoverished as well. So lastly, I think looking after yourself, being in the profession that you are, it is not easy. You are probably going to be dealing with a lot of difficult situations, as I had heard, people with very difficult situations where they're talking about harming themselves or in very stressful situations. So I think it's really beneficial to have small groups for yourselves where you're able to talk about difficult situations confidentially, of course, where you don't reveal names, de-identified. You're able to sort of workshop solutions there, because look, none of us know everything. We don't know everything. We can't solve everything. But in a group, we can potentially find some solutions. Seeking counseling yourself. I do therapy myself, and it's been fabulous. So I think seeing a professional for your own health needs, having a routine to look after yourself, spending time with friends, developing a hobby, learning a language. I think all of that really play an important role, and this is really, really important while you're being in such a difficult space. So that sort of brings me to the end of the presentation. So again, I'll stop sharing hopefully I didn't rush through. You can see there about, yep.
Dr. Aniruddha, this is Vidya Mahesh from Sneha Society for Counseling.
Yep.
So thank you so much for that insightful and thought-provoking presentation, and your perspectives have given us so much to reflect on. We will now move on to the question and answer session. Like you already know, we have got quite a number of questions through the Google form, and during the course of the talk, we have got answers to many of them. However, I would like to put across a few more questions, what has come to us.
Sure.
Yeah, thank you, Doctor. One person asks, few of my clients are addicted to work. Can you please suggest some coping mechanisms or how to handle it? Work addiction.
Yeah. I mean, I don't know if I classify this as a work addiction or not, but again, I think it's important to look at. I think it's to contextualize this. I think the milieu in which India, like I think if you look at America, India, I think coming to Australia has given me a little more perspective in terms of prioritizing needs and wants in life and what is important, right? The thing is, I think India has a culture where we all have to work really hard.
Yes.
You've got to be presenting your 100%. It doesn't matter if you're burning out. It doesn't matter if you're not eating properly. It doesn't matter if you're not doing things. So again, I think it's really important to contextualize, why is someone working so hard? What is that is driving them? I guess so. So I think to preface that, so first is find out why they're working that hard. What are things that they are probably missing out on, and maybe even try and focus on things they could potentially prioritize. If it's purely this joy of work, I haven't met someone who's been so invested in their work that they're only constantly doing it. I think again we go back to the basic tenets of looking at motivation and saying, do you want to change? Do you see this as a problem? I guess it's also looking at what are the problems from working that hard. So I can see a few things. So you're probably being quite stressed. There are ramifications on your physical health. You're probably neglecting your social and your family life. So yes. So I think it's an approach that you take carefully and looking at whether they want to make that change.
So it depends on the individual to have their work-life balance, basically.
And that context, yes. Because if there is someone who has to churn out a project in 10 days and their livelihood depends on it.
Right.
I don't know. Would I tell them, no, don't do it? I think it's a hard one. It's not going to be an easy thing to say, you know what? It doesn't matter. I don't have a job after 10 days after that if I don't finish up that project. Yeah. So I think it's really important to contextualize that particular issue.
True. Very understandable. The other question. Oh. Okay. The other question is that you did speak about vaping. You just began talking about vaping. So vaping has become quite common among youngsters these days, the young adults, and they even kind of normalize it. So how can that be addressed?
Look, this is a challenging scene and it's evolving, right? This is something that we're seeing here in Australia, across the globe as well. And unfortunately, I'm not familiar with the vaping regulations in India at the moment. So I can't give you a well-formulated answer, particularly to that. But having said that, I think I think it's really important to highlight what the constituents of the vaping are. So in my understanding, I imagine what they're putting in the vape is nicotine. And so I'd target this as I would if someone was smoking.
Okay.
So I think the multiple facets to normalizing this is that the smells aren't there. You get various flavors marketed in a manner that's very appealing. So again, I think there's so many issues with it that are rife. So it makes it a lot harder to challenge it. And the difficulty with nicotine is that, even with smoking, is that harms from smoking are not apparent now. They are apparent years later. So someone has cancer, they won't get cancer now, they'll get cancer in 20 years. They'll probably get breathing difficulties, which is irreversible in 20 years. So I think that makes it a lot harder to make them change as well. I think importantly, it's about educating people about the risks with it. What happens with vaping? There are rare issues of pulmonary changes which are permanent, people who have lost their lives from it. So I think it's also important about not knowing what they're putting in the vaping liquids. So I think it's really talking about what the harms from it are and letting that individual make an informed choice. And like I said, looking at what does the person want? Do they want to stop? It's about helping them along.
Yeah, true. There is a comment which says e-cigarettes, in other words, vaping is banned in India. But we also see the availability because it's on the list. Yeah. True. There's another question which says, how can one handle food addiction?
This is a tricky one.
Craving, doctor.
Yeah. This is a tricky one. And I think there's no easy way to address this because, again, food is something that we do naturally, right?
True.
Normalized to another level where you've got food vlogs. I watch food vlogs. I'm watching all of these Bangalore Eats and where the next dosa hut is and where the next masala dosa is. So, it's really hard to make shifts. And I think, again, I'd approach any behavioral addiction with the lens of what is the impact that it's actually having on you. Of late, there's a lot of talk about using GLP-1 analogs. I don't know if you're all familiar with it. So these are drugs like Ozempic, Wegovy, which again, a lot of people have used this with great effect, where it reduces the food noise, reduces craving, has been helpful for weight loss as well. So that's sort of one of the newer treatments. And I think when it comes to food addiction, I think it's important to look at what are the factors, what kind of foods are they eating, what are the timings of that food, is it related to an emotional state, are they craving something, are they craving something in particular, are they taking any medications that are making them eat more? So there's a few other things that you need to tease out with that. And again, if you think it's primarily related to just craving and not wanting to stop, I think it's largely based on the tenets that we talk about motivation, talking to them about how they can make a change.
Great. Yes. There's another question which says, how do we manage relapse? And what are the tools to manage relapse? And what is the success rate in relapse in substance abuse?
Yeah, I did try and touch on it a little bit in the presentation. So relapse prevention essentially looks at managing states that lead someone to use substances or the behaviors that they are engaging in. So it's addressing the negative or positive mood states, addressing their peer influences. So how do you teach someone relapse prevention? So what it is say I was going out and I met my friends every day at the bar, right? It's a social connection. So if I make a decision to stop drinking, that would mean I might lose my friends because my friends meet up every evening. So I have got to learn the skills of sitting with my friends and saying, okay, you can have a drink, but I can't drink. So it's about learning assertiveness there. So the friend will be, "Aye, parvagilla maga, one beer or yen agala," but they don't know what I am going through. So I think it's important because it does put one in a very difficult spot when you're sitting with friends or someone who's close to you. So it's about refusing. So it's about teaching them that skill. So there's assertiveness training there. Often I see that a lot of people, at least here in Australia, when someone's using hard drugs, say like heroin or methamphetamines, they've got to make strong decisions of cutting themselves off from these friends. These are difficult changes. These are life changes that they have to make. What are the rates? What are the success rates? Like I'd mentioned, about 40 to 60% of people relapse. It takes a long time for people to actually abstain entirely. So, like I said, I think it's important to remind ourselves it's a chronic relapsing condition.
Okay, interesting. There's also a question about mobile addiction in senior citizens, which disrupts their sleep. How do we counsel them? And there's another question in the chat also wherein it says, what are your thoughts for someone who's addicted to certain TV dramas or simply screen addiction, and also who doesn't want to stop it?
Yeah.
You emphasize on what do I want. Here the person says, I want to watch.
Yeah. So I think I guess that's sort of, it's really important to contextualize that difficulty. And it sort of takes me back to that boy who was gaming in his room, right? He only wanted to game. I think he wasn't able to realize what happened. I think it becomes problematic. I think the concerned family member is going to be worried if they're constantly doing this. And look, I'll be honest, I have this conversation with my folks. I have it with my dad. There's little recognition. But again, don't want to put him on the spot. But I guess it's rather than saying, hey, you know what? You need to make a change. I think it's about really engaging in things that they can do that give them that sense of uh, enjoyment and joy. The problem with screens today is that they have also hijacked that circuit incredibly well, right?
Yes.
YouTube shorts, your TikTok videos, so our attention spans are also sort of reducing as we go in terms of our ability to tolerate something that is long. So it is challenging. I'd say even just starting with small increments of having time away from your device is a start. I'm watching 5 hours. Okay, let's cut it down by 15 minutes. Fine, that's a start. We don't have to do anything drastic. Let's not do cold turkey, 5 hours, stop. Start with 15 minutes. See how you go. And I think the important key with any addictive behaviors is getting people to experience pleasure from other things again, right? So that's another feature.
Yes.
Where they are unable to experience pleasure to the extent that they would before. It takes time. Right. So it's about getting people re-engaged with things that get them pleasure. It might be having a conversation, sitting outside, going to Lal Bagh. I don't know. It can be something.
Yes. Understandable, because at that age, that is what they feel like doing. But probably they don't understand that there are activities, which they can engage in to get that kind of happiness. So, there is one question in the chat box which says, somebody has asked me, would like to know how many different kinds of substances and their specific impact, if any, like you mentioned, cannabis-induced psychotic disorder, from Dr. Shweta.
Right. That's a very broad question. But I think just to sort of preface this, so I think if people are using psychedelic agents, so things that interfere with your perception, they cause you to hear, see things, make you see colors. If you're using stimulants, something like cocaine, methamphetamines, all of these can potentially increase the risk of a person developing a psychotic disorder. They can also potentially cause someone who has a vulnerability to have a mood disorder as well, where they can have, right? Now, things like alcohol, the alcohol and anxiety are bidirectional. Sometimes people can use it to help with the anxiety. Sometimes drinking alcohol can result in having an anxiety disorder as well. Often when people are withdrawing from alcohol, they'll start feeling edgy, anxious, and it takes time to tease that out. And I think, so I don't know if that answers your question, but happy to sort of send across references. And look, there are so many substances that there are which have a multitude of effects, which I don't know if I'd be able to cover in this short span of time.
Actually, what happened is that most of the time when client comes up and tells me these are the substances, I don't know that what substance they're using.
Oh, right.
Right. It's just not the cannabis, because kids come and they say, "Ki, ma'am, he's using this," and I don't know even heard about them. So that's why I want to know the terminologies so that I can also refer them.
Right. I might actually refer you back to that drug wheel I showed you at the start. So essentially it gives you a classification of the substances. You can just Google drug wheel and put in an image. It'll just give you a list. And it's reasonably comprehensive, right? I think yeah, so it gives you a sense of what people might be using, and then you can read it. And it classifies it as well in terms of what the effects are on the brain.
Okay, thank you.
Mr. Vishwanath has raised his hand. Mr. Vishwanath, you could just unmute yourself and ask.
Can you hear me?
Yes.
Yes.
Okay. Yes. Hello, Dr. Aniruddha. It was a fantastic presentation. I really enjoyed it. I have one question because I used to work in addiction counseling. So there, many people used to come and tell me that there was a particular ad in television or newspaper regarding de-addiction, some tablet, if you mix it in a food or in some drinks without their knowledge, they can quit alcohol, something like that. And I was not aware of it. And then when I researched about it, and I got to know it's basically a chemical called disulfiram, if I'm not wrong. And you mix in the food, basically they vomit whenever they touch alcohol. So I got to know that that was unsafe to use without monitoring. So with monitoring in a rehabilitation and all those sort of places, they are supposed to use it. So whenever they ask, can we use the ad, that particular kid or that particular de-addiction thing which they show? So can we say, yes, you can, or can we say you should consult a psychiatrist? So what's your take on such advertisements without, it's like a over-the-counter medication they are advertising. So what's your take on that?
That's a great question, and it's a very common scenario. We see this a fair bit. I think the first thing is your answer should be no, do not do it. Answer should be consult a psychiatrist. Disulfiram is a great medication if someone is motivated to stop drinking. So that is very important. So if I am continuing to drink and I don't want to stop, and you put disulfiram, I could potentially have a life-threatening reaction and die.
Exactly.
So
yes,
it's rare. So you would definitely not recommend putting it in someone's drink without them knowing. We recommend disulfiram only to people who are like, you know what? I know I'm going to stop. I just need something that was going to help me. If I'm in an environment where I'm with friends and they are drinking, if I take this, I know I'm not going to drink, right? You need to have that level of conviction to be able to be prescribed this medication. So I would definitely say, and I think if someone were to ask you, just say that is not recommended. Please consult someone for help.
Yes, thank you so much.
Mr. Sumit, you could unmute and ask your question.
Thank you. Doctor, I work with young people, and a lot of them come up with addiction to pornography. Any thoughts about that?
This is a challenging space again, right? I think it's so many layers to it, and I think with access these days, it's a lot harder. And I guess I think there's so many unrealistic expectations in terms of how people view this. It is a challenge. I'll be honest. It's a very challenging spot to be in. And I guess in your conversations with them, I think it's really important to have normalized discussions around what sex means, how it actually works in the real world as well. Because again, people can have unrealistic expectations that are sometimes set with what's portrayed in pornography, and that can have significant ramifications for their behaviors going into adulthood as well, in terms of their expectations of women, what they'd expect to do as well. So I think there's another layer to that. And I think if you're dealing with someone who's coming in with, say, a difficulty controlling it, I think it's about taking a stepwise process in how they are able to actually cut down. The difficulties with pornography is because, look, sex is normal, masturbation is normal. People use their imagination. That's part of growing up and development. So there is normal sexual development. And unfortunately, what pornography does is, again, it sort of hijacks that normality around it. And what that means is it leaves people without that imagination and being able to actually carry out what they like to do and experience that pleasure as well. So I think it's also about rejigging that when you're talking to people who are addicted or using this as a means. So I think I'd say first, just about making sure they're fully aware of what they're doing. looking at how they'd like to make a change if they do want to make a change, talking about reasonable expectations about what gender roles are, and this is not reality and that it's sort of filmed. So I think those are probably things that you could potentially do. I don't know if that, I don't think that would fully answer your question, but hopefully that's something to start with.
Thank you. Thank you.
Dr. Vasudevan, you may please unmute and ask your question.
I wanted to bring out the sources and resources that are available to counselors. And WHO especially addresses this in their mental health promotion book, that indigenous sources offer quite a few resources. And I can't think of anything better than the Bhagavad Gita or the Yoga Sutras. And the US Surgeon General, Vivek Murthy, brought out the importance of spirituality for mental emotional health care. And I think we are neglecting that.
Couldn't agree with you more. Sorry, I could see you've put that message in the chat as well just now. Thank you for highlighting that. I did want to sort of touch on that because I think in I think spirituality plays a huge role in our development as well, and being able to experience life as it is. So I think it's a really important point that you bring out. There's a lot of wealth of sort of knowledge there that we can actually draw on when you're speaking to people coming to you with issues as well. There's also data to say that people who are steeped in sort of religion and spirituality also probably tend to have lower rates of substance use. But again, so I think thanks for highlighting that.
Doctor, do we have time for 2 more questions in the chat box?
Yeah, sure.
Okay, so there's one question a participant has asked: is it advisable to talk to the client about the transition from high risk to low risk to no risk? Is it advisable to talk to the client about the transition?
Right. High, I don't quite understand what the risk is from high to low to no. As in, what risk are we talking about?
Mr. Satish Joshi, if you're there, would you like to rephrase your question? Okay, we go ahead with the next question, Doctor. Talking about change, can lack of motivation for wanting to change come from a neuro or chemical or hormonal imbalance or any deficiency?
That's a great question. And yes, so there are some times where people have brain disorders that prevent them from actually wanting to make a change. So if there's someone who's got a frontal lobe deficit, they are constantly impulsive, they definitely may not have the thinking power to actually go ahead and do these things. People who might have an intellectual developmental disorder as well. People with so I guess can there be hormonal conditions that contribute to their inability to make a change? I'm not sure, but yes, there are definitely neurological conditions that could lend themselves to impairing a person's ability to make a change.
That comes to the end of the question and answers. Do we have any more questions? Okay. So thank you so much, Doctor, for answering all the questions so patiently.
No worries at all.
Yeah, thank you. I take this opportunity to express our deep gratitude to our distinguished speaker, Dr. Aniruddha Narasimha, for an enlightening and thought-provoking presentation. Doctor, your insights into the causes, the psychological dimensions, and the social implications of drug abuse among adults have been both informative and inspiring. Thank you so much. Thank you, dear participants, for your active engagement and thoughtful questions that made this session truly interactive and impactful. My heartfelt thanks to all the members of the Sneha Society for Counseling for organizing such a wonderful webinar. As we conclude, let us remember that combating drug abuse is not the responsibility of a few, but a collective social commitment. May the knowledge shared today inspire us to build awareness and extend compassion to those affected. Once again, thank you all for your presence and participation. Have a wonderful evening ahead. And good night, Dr. Aniruddha. Thank you once again.
Thank you all. Thanks for having me. Bye-bye.
Very, very nicely done. Congratulations, everybody. It was beautiful. Rupa for the speaker, Lakshmi and Vidya for whatever you did.
Awesome job.
And of course,
very well conducted.
Yeah.
Session was good and it was conducted also very well. Thanks, Lakshmi, Vidya, and Rupa, who brought in the good speaker. Yes.
Yeah.
Thank you.
Good. Very nice.
Thank you so much. It was a joint effort. All we Sneha people.
Of course. Yeah, nice. And anyway, it was good.